I am Donna Klassen. I am the co-founder and CEO of Let's Talk Menopause, a national nonprofit changing the conversation around menopause so women get the information they need and the healthcare that they deserve. Our menopause talks are central to our education efforts, and you can see the past 15 of them on our website at letstalkmenopause.org/talks. These menopause talks are for informational purposes only and not as a substitute for medical advice. A few housekeeping items. We've disabled the chat. So ask your questions in the questions and answers, but please also look at the chat because we're going to be giving you information there, including links. So again, please ask your questions in the Q&A. We're going to have the last 15 minutes as time for questions and answers. We're also going to release a poll towards the end, and so please take that so that we can continue to improve our programming. We are welcoming our panelists here. We have a wonderful menopause talk, menopause stories from Black women and the doctors who listen to them. I'm going to just briefly introduce our panelists and then hand it over to Dr. Sharon Malone. So Dr. Sharon Malone is the medical director of Alloy Health, a telehealth platform providing menopause treatment. She is also a medical advisor to Let's Talk Menopause, and she is at the forefront of the menopause advocacy movement. Prior to this, Dr. Malone was a well-known, trusted OBGYN in Washington, D.C. for over 30 years. And she has been an incredible friend and resource to us here at Let's Talk Menopause. Rachel Hughes is a former dancer with the Alvin Ailey Dance Company. She's now the community manager at Alloy, and her diverse career also includes nutritional counseling, counseling patients with chronic pain, launching and hosting a podcast devoted to perimenopause and menopause, and writing. Dr. Sameena Rahman is a practicing OBGYN. After years of practicing in large academic settings, she's open to practice focusing on menopause and sexual health. She also researches and presents on implicit bias and works also hard to provide an inclusive environment, again, across all races, religions, and incomes. She also uses social media, video, and op-eds to get her message out to reduce stigma. Kamili Wilson founded Menopause Made Modern to address a gap in information, resources, and representation for women of color throughout the menopause transition. She shares content, tells stories, and builds community to inform and empower women to better manage their own menopause experience. So I'm going to hand it off now to Dr. Sharon Malone, and we hope you enjoy this menopause.
Thank you so much, Donna. I'm looking forward to this conversation because the good news is that we have had this conversation amongst ourselves, a lot of which started even a couple of years ago. I am an OBGYN who has treated menopausal women for over 30 years. And the one thing that I have found out is that even though the experience of menopause is universal, there are some things that are particular to communities of color, and particularly Black women. Now, as I got deeper into this, the study and the treatment of menopause, I found that there are things that do differ. We find that menopause affects Black women slightly differently. They go into menopause about a year earlier than white women. Their symptoms tend to be more severe and they last for longer. Now, we also know that there are certain cultural barriers, there are certain educational barriers about how we access care when we are experiencing the symptoms of menopause. And it matters what we know going into this experience and what do your doctors know in terms of treating and how to interact with patients of color. So I think that the first place to start is really with storytelling, because I would be very interested in having all of you know what has the experience been. We have Rachel Hughes and Kamili Wilson who are here and in various stages of their menopausal journey. And for those of you who don't really, who may not know, and you may not have heard all of our talks before, perimenopause or the menopausal transition can start as early as about 10 years before women have had their last menstrual period. And menopause, as we define it, which is when you've had your last period confirmed after 12 months of no periods, and you are menopausal for the rest of your life. And that has very different implications, not just in the transition, but what happens in thereafter. So my first question is really to Rachel, because I would really like for you to share with our audience how old you were when you sort of started this menopausal transition, and what did you know coming into it? Did you even recognize it as such?
Thank you so much for that. Thank you to everybody here. Very, very glad to be part of this discussion. I believe I was about 42, 43 years old. I think it probably started a few years before then. I knew nothing about perimenopause. I'm not even sure that I knew the term, the word. What I understood to be true was that you, and I'm paraphrasing what I thought was more or less a quote, that you are in menopause and it's over. And however you define it's over, it's over. So that was my understanding of what menopause and perimenopause was. My first symptom was, interestingly, anxiety. It was not the hot flashing. It was not vaginal dryness. It wasn't the things that we sort of collectively tend to associate with this transition. It was a mental health issue. And it felt acute, it felt dramatic, it felt completely unexpected. It was completely unexpected. And it was a sort of a journey to wind up in my doctor's office and get clarity on the situation. So yeah, that's the beginnings of this for me.
Now, 42 is pretty young to start experiencing. Most people think of menopause and they think, oh, well, that's older ladies. They're in their
Right.
50s or 60s when this happens. And sometimes now, when this anxiety started, it started, but you were still having your periods, right?
I was still having my period, and I'm 53 now, and I am still having a period. Yes, it goes on and on. And I feel like, in retrospect, as I stepped into this conversation solely selfishly to find out information, when I say I stepped into the conversation, COVID happened. I was scrolling on Instagram. I had by then heard the term perimenopause. I had by then been validated, understood, informed, educated that that's where I indeed was. And I went looking for resources, community, information. And in doing so, I realized that as I was scrolling endlessly, nobody looked remotely like me who was talking about this issue in particular. And of course, in part, that wasn't true. This was an algorithm thing, and I didn't appreciate how Instagram works and all of that. But in the moment, I thought, who is speaking to Black women? Who is speaking on behalf of Black women? Who is speaking for Black women? And I thought, I'm going to give it a go. I'm going to step into this pool and see if I can contribute something to this conversation. And as I did, and was fortunate enough to then speak to physicians, speak to specialists, speak to people who did in fact know a lot more than I did about it, I was slowly educated, and am still on that path. And I forgot your question. I'm sorry.
No,
I'm just talking and talking.
it's all right. It's all part of perimenopause, so
Yeah.
perfectly acceptable here. But here's the question that I have for you, Rachel, is that when you started experiencing those symptoms, so we're talking 11 years ago.
Yeah.
At this point, did you, since you didn't know what perimenopause was, did you seek care, and to whom did you go for that care?
Yeah. Thank you for that. It's interesting, as I was thinking about this conversation, I was thinking about the moments I had that sort of broke through the veil, if you will.
Mhm.
I was very fortunate to have a gynecologist who said, it sounds like this is perimenopause. And yes, indeed, I believe you're in perimenopause. And here's all the reasons why. I came in asking for a hormone test. She said, tap the brakes. That's not going to happen. Let's talk about your symptoms and let's see where we land. And she said, here are all the options that are available to you right now. And interestingly, her strongest advice was to stay on the pill. I was on the birth control pill at the time. Now, I had been on the birth control pill since I had my son at 25. And I also thought it's time to get off the pill. You know, just like everything should happen at once. I should just throw myself into menopause and just be done, you know, in the way that I understood it to be. And I didn't take her advice, and I went on to suffer for a very, very long time. And I started to think, as I was having these conversations and educating myself, I was becoming more and more aware of what I was suffering with, and starting to question my reasons why I was sort of comfortable staying in that place. And I was hemming and hawing all the time. And I had a friend who, again, sort of broke through that veil and said, well, why don't you just try it? You know, and she sort of simplified it and it as much as possible. And she said, you're on the pill for this long and now you're not on it. So why don't you just try it and see, maybe you'll feel better. And if you don't, then you can get off of it. And I still paused because my understanding was that hormone replacement, and sorry if I'm jumping the gun a little bit, but that the possible best sort of solution to address my suffering was something that could give me cancer. And that's how I understood menopausal hormonal treatment to be. And I wasn't sort of well versed enough in figuring out how to sort of assess the risk benefit. I just thought that's what's going to be down the pike for me, and it's going to be worse for me. And I'm going to get poorer treatment, and I'm going to have a more dramatic time of it. And my outcome is going to be, you know, I'll be terminal faster. And, you know, I was sort of playing out all of these things because that's what I understood it being hormone replacement or menopausal hormonal treatment to be for Black women in particular. And then again, I actually spoke with you, Dr. Malone, for a conversation for another platform. And you brought up particularly cardiovascular disease, heart disease, and it's sort of the benefits of menopausal hormonal treatment. And my father had just died of heart disease. And so things sort of came together very quickly. It was a cascade effect. And it was like the light went on. And I thought, well, here's the risk benefit. Things are clearer to me now. This is what could be in my future. This is what probably will never be in my future. And this is what I know for sure is not in my future. So then I started taking treatment, and it was like the clouds parted on night one.
Right. And, you know, your story brings up some very important points because you use the word suffering. And that comes up again and again and again in women's stories, and particularly in Black women's stories, because there is this sort of built into the lexicon, you know, that we suffer from things, and somehow or the other, we accept that as our lot in life, that we just have to suffer through, soldier on. And this is why I really want to hear, now I want to hear from Camille, because I want to hear your story, when it started and where you are in this process now. Because I think as we hear these stories, Dr. Rahman and I can really address what are those stumbling blocks? Like, what is it that is getting in the way of you accessing care that will not only make you feel better, that will also make you healthier? So with that, Camille, tell us, please.
Yeah, I'm so glad we're having this conversation, and I expected more to come away and share my story and learnings and insights, but I've actually never heard Rachel tell her story firsthand before. And candidly, there's not a lot of daylight between our experiences. I was 42 when 43 when I first began experiencing what I ultimately learned to be perimenopause. And I'm now, I'll be 50 next month. So I'm 7 years in to my perimenopausal journey, and really a little frustrated to know that it could go on for another 6 years, 3 or 6 years. So, but my first symptom manifested as as rage. It was hormonal rage, and it came up for me in the workplace, and it was incredibly terrifying to me, and very vulnerable because in my workplace I am high level executive, very visible profile, and increasingly I was having a really difficult time managing my hostile responses. But I knew that there was that it wasn't normal, that what I was feeling, because I was having disproportionate responses to what was being said or done to me, and it freaked me out. And I don't know. I think it was after that. Then there was some mild or changes to my cycle when I've always been very consistent. Comes like clockwork, 3 days, heavy first day, lighter, and then it's done. Well, then that changed, and then there were times where I'd have 2 cycles in 1 month, which seems like one of the worst things to experience. And it was just these string hormonal acne, uh weight gain, and it waning, gaining weight differently than I had before, and very difficult to take off. And ultimately through the Google machine, right? I think we're all practicing going to the internet to kind of figure out what's going on with us. And so that was my experience. And probably after about 6 months, I strung together that I was in perimenopause. Like Rachel, I don't believe I had ever heard the term prior to that. And after coming to this on my own, I did engage my doctor, longtime OBGYN, delivered my son. Apart from that, I'd been going to, and I started menstruating when I was 11. I've been going to an OBGYN since I was 13, and never, not once, ever, ever had I had a discussion with my OBGYN about perimenopause, menopause, or what to expect. And so that was deeply frustrating. But also in my own journey early on, and kind of looking for information, trying to understand what's going on with me. Again, like Rachel, I didn't see anybody that looked like me. I didn't see any stories. All the images that came back were very Eurocentric, white, not just that, but older, conveying white-haired women, which was not at all my experience or my understanding of what perimenopause is and when it starts and how it affects. And so I was pretty frustrated by that as well, and knew that if I was looking for that information, there were other women who were likely looking for that information. And so I feel like maybe throughout this whole talk, I'll be saying, like Rachel, after spending, time in the space, and particularly on social. I've never really particularly been active on Clubhouse, but that was my first. No, there are people out here who are having these conversations. And I just have to be more deliberate and intentional about finding them. And so then that ultimately just morphed into what I believe has been kind of my calling to do. Is I want to make it easier for Black women and other women of color to find relevant, useful information. And I want to present it as objectively as possible, because everybody's experience is different. But provide just really clear, excellent quality content, and let women make their own decisions. I do want to also speak to, and what I was struck by most, I think, with Rachel sharing her story, is her journey of reflection, resistance, consideration, resistance, and then acceptance of the role of menopause hormone therapy in helping with her symptoms. And again, like Rachel, like that has been the space that I've been in. And so that's particularly why I'm glad we're having this conversation, because I consider myself an educated woman, middle class, access to resources. Dr. Malone, you and I have had numerous conversations with your colleague, Monica, and I'm on the cusp. I'm on the cusp of considering menopause hormone therapy. I still am struggling with anxiety, struggling with hot flashes, struggling with horrible menstrual cycles, have been for years. And when I think about why is that? You are in this space. You were presented information countering what came out of the WHI. Why have you not made that move? Well, I've had a history of fibroids, 2 myomectomies, one very traumatic. I had an ovary removed, and the fallopian tube removed. And cognitively, I just think, oh, hormones can't be good.
Right. Right. And you know what, Camille, this is the conversation that we really got to have, because it's so important, because there's an educational deficit on both sides of this equation. It's the deficit in the community of women. We don't talk to each other. You may not have heard what your stories are from your mother. And the people that do talk generally do not get good information, because most people are getting it from their girlfriends or their hairdressers, which is really not the ultimate source. So, but this is what I want you to know, is that what we have also found is that Black women are least likely to complain of symptoms of menopause, because again, it gets into that mindset that, well, I guess this is just how it is. This is what getting older feels like. So they are least likely to complain. When they do complain, they're only half as likely to be given a prescription or even to have their complaints addressed. And even when they take that prescription home, they are only half as likely to take it. And these are pretty, I would say, from my point of view, devastating statistics, because again, we get back to this issue of suffering and why do we choose that? And now I really want to go to Dr. Rahman, because you see a lot of patients in this space. So what is it? How do you talk to your patients who, like Rachel and Camille, are coming in with these kind of complaints, and you realize you've got to break down some of those cultural barriers and resistance to treatment?
Yeah, no, definitely. So I have a practice in downtown Chicago, so I see a lot of variety of patients, and I make it an effort. I spend time with my patients, which, I think that is a limiting factor for a lot of clinicians, right? Is if they're in a big space in a big academic center or a big, practice where they have to see 15-minute patients every hour they're seeing 4 patients. There is no way you can sit down and have an actual conversation with patients about, debunking the WHI, asking them like, okay, maybe you don't have hot flashes. Do you have joint pain? Do you have, palpitations? Like, tell me all the stuff that you might have. Fill out this form, about, all the potential symptoms. So, there's a time limitation that a lot of clinicians have. And I'm lucky that I have my own practice that I can spend that time. But also it's a matter of like, catching them maybe even before the symptoms. I always say we give puberty talks. We should have peri talks. We should say, hey, guess what? You're 38. Maybe you don't have this right now, but this is coming, because, for anyone that lives long enough and or has, surgery for it or whatever the case may be. And it varies for every patient, but this is what you expect. And then I'll tell patients, why don't you talk? Is there a chance that if your mom is alive, can you talk to her about it, or your sister? Is there conversations you can start? Because this can dramatically impact your life. So I always try to do like a peri talk when I see, even younger patients that might be on the cusp, but also just, talking to patients like, tell me your experiences. I know, like, I've studied implicit bias. I've been a victim of implicit bias. I check myself a lot when, because it exists and nobody does it intentionally for the most part. I think that I tell my patients, tell me your experience, tell me what has happened to you in this frontier, in the world of menopause, in the world of healthcare. How have you been affected by your periods? We have open discussions about it. And then we just kind of talk after that, after having a discussion on where you're at and what you've experienced. Because in medicine, like anything, you can experience different types of trauma, from, a bad pelvic exam that precludes you from wanting to do pelvic exams your whole life, to, a negative experience with one person or another. So I think that, just acknowledging that, when you acknowledge that with a patient, that, and sometimes I'll just be frank. I know as a Black woman, you may not have gotten the attention that you needed, but I'm here and I'm going to listen to you. Because, you know, again, if you've studied implicit bias, if you've been a victim of implicit bias, you know it exists. And so being that aware, and, you know, and this is what I tell, you know, other colleagues and everything as well, that we should really try to make an open discussion with our patients and acknowledge their past and acknowledge our past with how we've traditionally practiced medicine through, you know, a patriarchal lens. But really, you know, because as we always say in menopausal care, it's not one size fits all. And it's always about meeting a patient where they are, right? Like, you're not going to say, I am going to give you hormonal therapy no matter what you say. People come in, I will never say that to a patient. I'll say, hey, this is your option. And if they're very reticent about it, then I just let them, you know, soak it up a little bit. Let's meet back in 2 weeks. Let's talk about your vaginal symptoms at that time. You know, like, we break it up, we break apart the appointment times so that, you know, we have the discussion. I'll let you think about it. Come back in a couple of weeks. Let's think about that aspect. Let's think about your sexual function. How's the libido? You know, we address all of these issues, but it's really a matter of giving them the time and listening. And I think that's what a lot of, in a lot of clinicians, they don't have that, or they're not able to do, to give that. And as you know, Dr. Malone, there's a deficit in what we learn, right? As gynecologists, as urologists, as internal medicine doctors, it's not even being taught for a lot of patients, a lot of doctors, or a lot of clinicians in general. So if the person you're going to doesn't actually know, they're still practicing medicine from 20 years ago, telling you not to take hormones because it's going to cause cancer, what kind of trust, like, can you continue to have in the system, right? But and a lot of that time, it's really like, you know, sometimes I see doctors that say, you know what, I don't know, I'm not an expert in this. Why don't you go see, you know, Dr. Rahman or Dr. Malone or someone, you know, they'll point you in the right direction. But I think we have to also, as clinicians, be honest with ourselves.
Right. And I think this knowledge gap on the part of physicians is real. It's a knowledge gap, and it's an access gap. And the one thing that I have found, I have had the good fortune of practicing for a very, very long time. And so I practiced for 10 years before the Women's Health Initiative came out. And we'll talk about that. Was the study, just for those of you who don't know, that's the study that really cemented in women's minds this link between menopausal hormone therapy and breast cancer, which has been very, very, very difficult to disconnect. But that's where it came from. But there was a time before the Women's Health Initiative when we actually thought that hormone therapy was good. And for a lot of women, it is. And for the same reasons that we talk about it now, not just for treatment of symptoms, but for some long-term health benefits. And I think that we have got to get this information out to doctors. But here's the problem, and here's the real problem, is that if we started educating every resident out there in internal medicine and OBGYN today, that pipeline for getting that information out to patients in clinical practice is going to take a decade. And what do we do in the meantime? And this is why I think the work that Rachel is doing, the work that Camille is doing, is important, because we have got to reach women where they are. And I think particularly when you're talking about Black women, the very things that we are most at risk for are some of the things that hormone therapy will address. And let's just talk about that for a minute. We'll do a little bit of myth busting. And Camille and you, Rachel, both of you, the breast cancer thing, you keep thinking, I don't want you hold back because you are afraid that you are doing something dangerous, or this is going to cause me more harm than good for this therapy. So Dr. Rahman, please knock that myth down for us for a minute to explain to all of our viewers out there that why that is not the case.
Right. And I think, you know, it goes back to the WHI, which was the largest study in probably history for women's health, looking at whether or not, you know, hormones, you know, had really a protective effect. And they stopped in the middle of the study, you know, saying that there was a 26% increased risk in breast cancer, which, you know, through all the analysis of this huge amount of data that we have, I mean, it's just a ton of data, you know, there's really, when it comes down to estrogen or estrogen plus progesterone, really no increased risk in terms of, you know, breast cancer. You know, when they talk about the synthetic progesterones that were used, if you look at that data even closer up, that was the one that was thought to like maybe have a slight increased risk. They looked at the patients that had been in both arms, and the ones that were in the estrogen and progesterone versus the estrogen alone arm were actually patients that had been on hormone therapy before. And so, when those patients ended up having, less impact of the hormones, it was actually demonstrated that, there was no change and actually no increased risk. And if you think about drinking, 1 glass of wine a night, it's actually going to be the same. I think it's like up to 7 drinks in a week gives you almost the same risks. If you're looking at it from that perspective. So it's kind of like you choose which way you want to go. And, so the breast cancer and then the longevity, these patients ended up with, the patients that were on the hormone therapy or that got taken off of it actually had lower life expectancy, increased cardiovascular risk, and obviously, like, the bone density we know is protective too with the estrogens. So really, looking at the data nice and closely, patients can really be reassured overall when it comes to breast cancer risk.
And I think that's a real important point because, and particularly when it comes to Black women, because here's the story with Black women and breast cancer. Black women and white women get breast cancer roughly at about the same rate. We don't get more breast cancer. We get a more aggressive type of breast cancer because there's a slightly higher risk of the higher risk breast cancer in African American women. But this is something that I think got totally missed from that study, is that they had women who were on estrogen only. Because remember, if you've had a hysterectomy, you don't need to take both hormones. You don't need estrogen plus progesterone. All you need is just the estrogen. And who gets hysterectomies more than anyone in the country? And that would be African American women. So there is this huge population of African American women out there who have had hysterectomies. That's number one. So what happens to these women who have had hysterectomies? They take estrogen only. Guess what the Women's Health Initiative showed? It showed that for women who take estrogen only, when they are followed, and they have 20 years of data now on this, that these women had not only a decreased risk of developing breast cancer, 23% lower risk of developing breast cancer than women who did not take hormones. And more importantly, their risk of dying from breast cancer was 40% less. And that is a message that I think that we can't say enough, because to not only undo some of the negative associations that you have for African American women, it may be, and particularly those who have had hysterectomies, estrogen therapy will improve the quality of your life, improve the length of your life, because those women also lived 30% longer than women who did not take it. And these are the kind of messages that when you look out here in the world, you're like, why aren't people saying this? Because these are people who are most vulnerable for cardiovascular disease, for dying of breast cancer, and for all the things, for high blood pressure, type 2 diabetes, which also decreases the risk of taking hormone therapy. And so I think that we have got to do a better job of making the case, because, as I say, my job is not to say to you, take it or don't take it. I want you to be able to have the information that you need to make a good decision based upon some scientific data, not the things that we think or bad information that you may have even gotten from your doctor. Go ahead.
If I may, I also think that it's critically important to talk about, and Dr. Rahman addressed it a little bit, around the role of trust of the healthcare system. And I think particularly for Black and brown people and Black women, there's a trust factor, right, that compounds the data found in the WHI study. Oh, that was misinformation. Okay, but it's okay to take hormones. Are you sure? Because Black women disproportionately are affected by it, right? So when I say now, after several conversations, and I now have a relationship of trust with you, Dr. Malone, right? Like, this woman would not direct me to something that she will not do herself, that would cause me harm. It's so important, I think, not for everyone, but for many women, to be able to trust that they are experiencing culturally competent care as well. So I think
Can I
that's
get-
a big barrier.
I get it.
I just want to piggyback off of Camille's statement as well, that the trust, I think, is so embedded in these conversations. And by these conversations, I mean not just here, but amongst people like me and Camille, who are lay people, really having an experience speaking to other lay people, if you will, about what we're going through. And in my sharing a little bit of this 10+ year journey, that might be impactful and helpful and help to sort of bridge the gap between what we're experiencing as just regular women walking around and what our physicians are telling us, where there is this possible piece missing, this trust piece, if you will. It matters. It matters to help drive correct information forward. It matters in terms of, as you said, Camille, so beautifully, this woman would not put me in harm's way. And the other piece really is that, and we've said this plenty, but really to hear from other women who look like us it's hard to sort of put into words how important that is. It matters that there are more Black and brown researchers in working for pharmaceutical companies, as physicians, as clinicians. All of that makes a difference. It makes a difference to hear somebody who resembles you at all say, well, I've done it and I did it for the last 45 years and I'm doing great and my labs come back great. And oh, by the way, I have a history of XYZ in my family and I'm not showing up as any of that. So it's not about sort of twisting someone's arm into it. It's just sharing from where you are. And for me anyway, when you resemble it all, it matters. I might just listen that much more. I might just listen that much longer. I might just be that much more interested. And anyway, so all of that is really critical.
And I get it. Cultural competency matters, on the part of physicians. But here is also, as we get back to what I was talking about earlier, is about our access problem and how are we going to fix it? Because it's great to be able to have a physician that you trust. But the reality is that we're living in a world where you are never going to have the type of long-term relationships with your physicians that I was able to have with mine. I mean, my career, I'm at the end of my career, and I literally had patients that I have taken care of for the entire 28 and a half years that I was at this one practice. That's not how medicine is going. It is in a direction where it's going to be less and less personal. The person that you're going to interact with is going to know you. Least of all, that person you may come in the next year and you'll see a completely different doctor. You'll see a nurse practitioner. See a PA. And this is why I cannot overemphasize enough how important it is that, Camille, what you do, what we do at Alloy, what Rachel does, and what Donna, because we have another way to get this information out to patients, because I do believe this. I believe that women don't need to be told what to do. I think that when you give them information, give them good information, that then they can make decisions for themselves about what makes sense for them in their healthcare. And the reason why I continue to talk so much in this space is because it's not just what I believe, it is what the science says about what things that particularly African-American women are at risk for: high blood pressure, diabetes, obesity, sleeplessness. And all of this contributes to a much, I would say, worse outcome in terms of their long-term health. And this is why we've got to get back to this and say, understand, my job and Dr. Rahman's job is to make the case and let you decide. But we're going to have to make the case differently because, again, we don't live in that world where you're going to see a doctor for 20 years. And you may or may not, trust may not be the important thing in this type of environment. Competency is, but not necessarily to think that this is somebody I'm going to be with for 10 years. So I really want us to all continue to do what we do, such that this information is out there so we can counter some of the negative voices that you may be hearing in the community. I think that we're all doing our best to get it out there. And Camille, we're going to continue to work on you because I want you to feel better.
I have to say also
Camille,
that
we need a conference call.
Yeah.
I just want to reiterate that actually, Dr. Malone, because I now in the past, I guess a year and a half, like I think the menopause moment has been happening over this last year and a half where people are speaking out. I know you were on Oprah and all the things and people are writing books. So I love it when patients come to me with information they've already acquired. Some doctors are like, oh, I hate when the patients Google and then they tell me all this stuff or that. I actually love it, even if they come to me with misinformation, from TikTok or, something like that, because at least it opens up the conversation, right? They come to me with like, oh, look, I read in this book, or I had spoken to someone on My Alloy, or, this and that, and they'll tell me the exact information they got. And then we review it and I'm like, yeah, that's good information. Or sometimes they come in and they say, I know exactly what I want. Are you going to be able to give me hormones? And I'm like, yes, let's talk about if you're a candidate or not. So I think this is wonderful. And you guys, let's talk menopause. Everyone in all the space has been wonderful, just amplifying the voice. And, once we get our government to buy in, then I think we'll be all good in terms of expanding our research and getting those black box warnings off and all the good stuff that we need to do.
Okay, you know what? we're going to take a few questions, but before we do, let's go through a quick lightning round of just misperceptions that are out there in the world that women think. Okay, so first one, and I think the most important one, is the link between breast cancer and hormone therapy. Because if you had to look at what is the most common reason why women refuse to take hormones or don't entertain it as a possibility, is because they think that it is the risk of breast cancer. So, Dr. Rahman, yes or no? Fear of breast cancer, is that a reason to avoid hormones?
Absolutely not. Absolutely not.
Agreed. Absolutely not. Okay, how about this other one? I have a family history of breast cancer, so I can't take hormone therapy.
Absolutely not. Absolutely not. And it's just, when I have those patients, we get them genetic testing if they meet the criteria and we go from there, but it's not a reason not to do it.
Exactly. And I will do a little sharing here. I have 2 sisters who've had breast cancer. Now I'm one of 5 girls and 3 boys, by the way. So a lot of people in my family. So we could do our own personal study of cancer, you name it. But I do have 2 sisters with breast cancer, one with premenopausal breast cancer, one with postmenopausal breast cancer, for completely different reasons, because premenopausal breast cancer and postmenopausal breast cancer are 2 completely different, almost completely different diseases. And let's take some comfort from the fact that breast cancer in early stage breast cancer and early diagnosis is a completely treatable disease, and 90% of those women will survive. So that's that. Now you weigh that risk, which is minimal, because let me say what the North American Menopause Society, or now the Menopause Society, has said about family history of breast cancer and use of hormone therapy. Your risk of developing breast cancer is your risk. Is based on any number of factors: how much you drink, whether or not you exercise, whether or not you're overweight. A host of environmental and lifestyle factors play into that. Your risk is your risk. Now, and again, we're excluding people who have the genetic variation. What does adding hormone therapy do to your risk? Nothing. There is no combination of the 2. So if I don't know if you're going to get breast cancer. You might get it 10 years from now. You might get it in 2. But the thing that happens a lot is that hormones get the blame for your breast cancer, because I've had patients who've taken it for 6 months and they get breast cancer and go, see, I knew I shouldn't have taken that hormone therapy. that is something that I want you to sort of disassociate in your head. Your risk is your risk. And, if a lifetime, 1 in 8 women will get breast cancer, the overwhelming majority of women who get breast cancer do not take hormone therapy. So keep that in mind. So don't use that as a stumbling block as to why you are going to avoid hormone therapy. Let's see, another that comes up a lot. Another little thing that comes up. Black women don't get osteoporosis. That's what I was taught. What about you, Dr. Rahman? Was that the prevailing thought?
That's what a lot of women believe, actually.
Yeah.
That it's like a thin white woman disease, or a East Asian petite woman disease, which is absolutely not true, right? So I think that has to be debunked, and we know that estrogen will protect those bones, and it's probably the best protection for those bones, along with strength training and calcium and all that stuff. But it's not true.
And here's another little factoid that most people don't realize, that a hip fracture is often the penultimate event in a person's life. Because once you have fractured a hip, it's not necessarily that the hip fracture kills you, but it's all the other complications that ensue after your hip fracture, your loss of mobility, your the weakness and everything that happens as a result of that. It usually sets you up for ultimately your demise. And if any of you have had elderly relatives who've been in nursing homes, you know what happens after that. Black women, now this surprisingly, it should surprise no one, but Black women who after hip fracture do worse. So that is just something that, you can plug in any disease and say, all right, here are white women and Black women, who does worse in that scenario. So the implications of a hip fracture in African-American women's is far more dire than the implications of having a hip fracture in white women. So that's something else we want to knock down here. All right, so let me go. I'm going to see if I can go to a couple of questions and see what anyone has here. Okay, well, this is someone who says, some of these questions I cannot answer. Someone says, I've noticed my pH balance, noticed changes in pH balance. Is there any natural way to fix this? Well, let me tell you this. The easiest, one of the things that happens in perimenopause and menopause, due to the lack of estrogen in your vagina, the vaginal mucosa thins, gets dry. You didn't even get to the sexual dysfunction issues for women who are in perimenopause and postmenopausal. And those changes in the pH changes the flora, the bacteria that live in your vagina. So the easiest, most effective way to treat that is really with topical vaginal estrogen. And just about anyone can take that. It doesn't even, whatever you think about hormone therapy, the use of local topical estrogen in the vagina is a no-brainer. So that's how we fix it.
And I also want to reiterate that vaginal estrogen isn't just for the pH. It isn't just for sexual pain. It is for those urinary tract infections that when you see an 80-year-old woman get a urinary tract infection, she may or may not get urosepsis, and it may lead to her demise as well. So I often say that vaginal estrogen can be life-saving. And, you have to think about, your urinary tract and your bladder and all that stuff as well. Some people think, oh, I'm not dry, or maybe I have a little urgency, but vaginal estrogen or vaginal DHEA is very, it's probably like the most important, and most people can take that. You're right.
And here's something that often I will hear a lot of women say that, when we're talking about menopause and perimenopause, and they'll go, oh, I didn't go through that. I'm like, you did. You might not have had symptoms, but you went through menopause. If you haven't had a period and you're a woman of a certain age, you have gone through menopause. And so what I want women to be aware of is sort of the silent effects of menopause and perimenopause and lack of estrogen. Weight gain is one of them. And it's not just weight gain. You gain weight, you're going to gain weight with age regardless. Hate to tell you this, but that's true for most women, but it's where you put the weight. And it's sort of for women who do not take estrogen, more of that weight goes around your middle as opposed to hips and thighs. And that weight that goes around your middle puts you at higher risk for cardiovascular disease. So that's another one of those things that you may not think of, or again, you think of it as an inevitability. And I think we would be remiss, and let me just say this, because I will say this again and again and again, even though we're talking a whole lot about hormone therapy. Again, as Dr. Rahman said, it's not for everyone. It works really well for most people. And I think that you have to understand that where we have come to this discussion is to saying, for women who start hormone therapy around the time of whenever you're menopausal, be it by hysterectomy or natural menopause, or sometimes even chemotherapy, the earlier you start, the better in terms of preventing some of these long-term implications of hormone deficiency. So there's not any real virtue in suffering for a long time. When you're symptomatic and you're bothered, that's the time to treat it. So don't wait. I use this analogy all the time with when back in my OB days, when patients would say, "Oh no, I don't want an epidural." I'm like, "Okay, your choice." And then they wait, and it's like 10 hours in, 12 hours in, and like, "Are we close?" I'm like, "No." And then they'll say, "Oh, well, okay, well, now I'm going to get your epidural." Now, ask yourself the question, was it worth that 10 hours? You could have had this yesterday, you know?
You could have been sleeping.
And that's the same thing with hormones. There's no added value at all for suffering or just to see how long it's going to take. You know, some women don't have any symptoms. Good for them. But don't think that because you did not have symptoms that you're not at risk for these other things. And that's why I said just as we were talking about the vaginal dryness and the urinary tract infections, that usually comes up really many years after.
Right.
And so you may not connect the two, but they are certainly related. So
can I just say one thing too about those silent symptoms, or to those women who say, "Oh, I didn't have that." I've had many conversations with women who said, "Oh, I sailed through," and then, you know, once I'm able to look at them again, because I hate hearing it, and we might sort of go through some of the symptoms, and inevitably there are things that women didn't know were symptoms, like very dry skin, or even body odor, dry mouth, itchy ears, dry eyes, vertigo. You know, there's the heavy hitters that are on repeat that we just know and associate. But there are so many, that joint pain, muscle aches, you know, just things that you go, "Oh my gosh, I could avoid that." And again, not selling, because I know you always talk about, both of you physicians always talk about this, but the nutrition piece and the exercise piece goes without saying. You know, please dial that in. It does change when we're older, meaning our fitness routine might need to change, or the things we used to be able to eat or drink might need to change. But those things matter to our overall health anyway. Doing what we can about stress mitigation matters anyway. The estrogen I feel sort of like envelops it all.
exactly. I think that's a very important point, because how healthy you are coming into this process is going to affect how you navigate those waters, regardless of where you come out on the other end. So there's never going to be a situation where I'm going to tell you that exercise and diet and sleep and stress reduction are not going to be helpful. And that's for just about any disease process that we talk about, not just perimenopause and menopause. So, but I think we get into that frame of mind where we think that, okay, I'm just going to go get a pill and fix it. No, it doesn't fix everything.
It doesn't fix everything.
Even after you've had the hormone therapy, you still need to maintain a healthy life. That's important.
And then I think it's important to say too that the old adage was, "Oh, hot flashes can't kill you. Like, you know, vasomotor symptoms aren't going to kill you." But guess what? We now know that hot flashes and vasomotor symptoms are, you know, put you at risk for cardiovascular disease, you know, metabolic dysfunction, visceral fat, insulin resistance, all the things that ultimately, remember, will kill you, because cardiovascular disease is still the #1 killer in women.
Right. And I think that That is also something to keep in mind, even though we worry so much about breast cancer. Starting at age 40, for every decade thereafter, more women die of heart disease than die of breast cancer. And that is also something that I think that women really do not understand. And I want you to know that, because these are things that could be preventable, and certainly by lifestyle, by diet, by exercise, by managing all those things like high blood pressure and diabetes would put you at risk. So we can't forget that the use of hormone therapy is one of the many tools that we have to use to make sure that we age healthfully. We don't want to just live long. We want to be healthy. And I think that don't take one of the important pieces in that toolbox out of it because you may have actually just thought, have some misperceptions about how things are supposed to be. So I think we're getting to the end of the hour. So does anyone have any parting ideas that you'd like to share with our guests? I got a question for you. All right, Rachel, knowing now what you know, is there anything you would do differently?
Yes. I would have taken my doctor's advice. I would have started hormones years before. And just to close this, you always speak about this. You both always speak about this. The suffering piece is not mandatory. It's not necessary. It's not.
You're not going to get a medal for it.
You're not going to get a medal for it, and it was never something that should have been. Never, never, particularly for Black and brown women, for Native women, never. With that, just to circle back, I was suffering. I was uncomfortably ruminating with an average of 40 hot flashes a day. That was not including night sweats. I was preparing mentally to muscle through that until I learned otherwise. And the piece that shifted it for me was about cardiovascular disease. There was just a death in the family. I was teed up for it. The whole family had this particular thing. And when I learned that I was primed and ready to have that be my future killer, I said, enough. But I didn't have to wait that long. And I didn't have to suffer with all of the other symptoms, mental and physical, for so many years. So please, 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 if you're on the fence, find a menopause practitioner who can speak to this and to you. Speak to a friend, reach out to Camille, reach out to me, and find out more. It's the suffering is unacceptable.
Unacceptable, exactly.
Agreed.
Thank you all. This has been fantastic.
Oh, no, I didn't mean to be
we
the
might have to
last
have a conversation number 2,
Yes, absolutely.
Forgive me for
We can
speaking so
delve
much.
into sex. We have to delve
Yeah.
into sex a
And
little bit.
cardiovascular.
Well, that's actually,
And
yeah, we have our next, that's a great segue in.
Oh,
Our next menopause
right.
talk is Come One, Come All, Midlife, Menopause, and Orgasms with Dr. Lauren Stryker, hosted by Nina Collins. It's going to be a fantastic talk. I'll put up on the screen the QR code, but you can also go to our website and I put the link in. I want to thank Dr. Sharon Malone, Kamili Wilson, Rachel Hughes, and Dr. Sameena Rahman. This has been a really incredible talk, and it actually got me thinking a lot during this talk about how we need more women's stories in these talks, to have women's stories with their providers in a conversation, because I think everyone benefits, and I hope that our audience benefited from this. I know they did. I know I did. And so I just want to thank everyone for coming.